A very good evening to one and all. On behalf of Neurocritical Care Society of India and Classroom Series, I welcome you all to today's Journal Club. We have the team from AIMS Delhi today to present a very important trial, which is the Profi VAP trial. As we all know, VAP is a significant problem in neurocritical care. And let's see ceftriaxone, which is the drug which we use for many other indications in the neuro ICU, solves that problem for us. The moderator for today's Journal Club is Suman Ma'am. She's presently the Associate Professor in the Department of Neuroanesthesia and Neurocritical Care at AIMS New Delhi. And we have with us a DM resident and enthusiastic Dr. Mohammed Sali. Over to both of you for today's Journal Club.
Is my screen audible and visible now?
Yes, you are visible and audible.
Okay. Good evening, everyone. Today in Journal Club, we will be discussing about the ProfiVap trial. This has been published in the Lancet Respiratory Medicine in January 2024. Ceftriaxone to prevent yearly ventilator-associated pneumonia in patients with acute brain injury. A multi-center, randomized, double-blind, placebo-controlled, assessor-masked superiority trial. So ventilator-associated pneumonia (VAP) is a leading cause of infection in critically ill patients. This increases ICU stay and healthcare cost. Patients with acute brain injury are especially at risk of developing yearly VAP. The incidence that has been reported in the literature for severe trauma patients varies from 20 to 71%, and for stroke it varies from 28 to 76%. The ProfiVap trial aims to evaluate the effectiveness of yearly single dose of ceftriaxone in preventing yearly VAP in patients with severe brain injury who require mechanical ventilation. So, why VAP incidence is high among acute brain injury cases? So, the patients with acute brain injury might have reduced cough reflex and sensorium, because of which they might have frequent aspiration from the oropharynx. These microbial organisms enter into the trachea before the actual tracheal intubation. These patients are at risk of having prolonged mechanical ventilation, and they may also have impaired immune response, which make them more susceptible to infection. Coming to the study design of the study, the ProfiVap trial was a multi-center, randomized, double-blind, placebo-controlled, and assessor-masked superiority trial. It involved 9 intensive care units across 8 French university hospitals. The study was conducted between October 2015 to May 2020. The study included comatose patients who have GCS less than 12, age more than 18, and who required mechanical ventilation for at least 48 hours after acute brain injury. The exclusion criteria as follows: patients with coma due to tumor, infectious disease, or cardiac arrest; if there is high risk of death within 48 hours after admission; if there is any ongoing antibiotic treatment; if antibiotic prophylaxis is expected within 24 hours of randomization; tracheal intubation by nasal route; subaortic secretion drainage; any contraindication or allergy to beta-lactam agents; participation in any other research protocol; or the consent refusal by the patient or family. Randomization and masking. The patients were assigned in 1:1 ratio using a secure web-based system. This assignment was stratified by the treatment center and based on the severity of unconsciousness. A computer-generated sequence was used. This was created by the statistician who was not involved in the patient recruitment. Patients, healthcare providers, assessors, and the study statistician were all blinded to the group allocation. So, after randomization, patients were basically divided into two groups within 12 hours of intubation and within 48 hours after hospital admission. They are either put in the group who received IV ceftriaxone single dose 2 gram, or they received placebo, which is a saline solution. Now comes the question, why ceftriaxone was used in this study. So ceftriaxone is a third generation cephalosporin. It has a broad spectrum activity against the targeted microorganism. It has long life, which ensures 24 hours of efficacy without the need of redosing. And the previous studies has been tested the cephalosporin and the guidelines tend to favor cephalosporin. Yeah. Coming to the methodology, the standard care was provided to all patients who were being mechanical ventilated. This includes hand washing before any care, head of bed elevation of head of bed elevation of 30 degree, and which was monitored every 4 hours. Heat and humidity exchange filters were changed only when soiled. The cuff pressure were monitored every 8 hours. Tracheal suctioning was done with sterile equipment, and it was only done when required. Mouth care was given every 8 hours at minimum. The blinding method: the use of Profivap labeled vials were used to prevent identification of the treatment. So the infusions were prepared by a nurse who was not involved in the direct patient care, and the syringes were made opaque and infusion lines were made opaque because the ceftriaxone has this brown color which can reveal the type of treatment. So in order to avoid it, opaque syringes and infusion line were used in the study. So the treating physician used clinical pulmonary infection score to suspect VAP in the patients. And the confirmation of VAP was done using American Thoracic Society criteria, which included clinical criteria, radiological criteria, and microbiological criteria. Either of the two clinical criteria plus one radiological and one microbiological criteria was used to diagnose VAP. So a central adjunction committee with consists of two senior intensivists who were masked to the study group assignment, reviewed all the medical charts and monitored data and chest X-rays and microbiological documentation. If there is any disagreement between two senior intensivists during the diagnosis of VAP, a third intensivist acts as an arbitrator to decide whether the patient indeed developed VAP. So patients who developed a documented pulmonary or extrapulmonary infection received curative therapy according to the local protocol based on the national guidelines. In 4 participating units, they conducted the rectal swabs were routinely performed at admission and discharge for the emergence of extended spectrum beta lactamase (ESBL) producing Enterobacteriaceae during the ICU state. Sample size calculation. The sample size calculation was based on the mean incidence of early onset VAP, which was supposed to be 30% in the control group, and they hypothesized that if the treatment was used, then it will be reduced to half, which is 15%. They used the statistical power of 90% to detect this difference, and type 1 error was set at 5%. This sample, based on these parameters, they evaluated that the study required 354 evaluable patients. This VAP incidence in the control group was based on the published incidence in the randomized studies of the patients with brain injury. So, totally 2,230 participants were eligible, assessed for eligibility, of which 1,885 patients were excluded due to various reasons. Then 345 patients were randomly allocated either into ceftriaxone group or into the placebo group. And finally, after exclusion, 162 patients were analyzed in the ceftriaxone group, whereas 157 patients were analyzed in the placebo group. Before going further, let's just discuss briefly about the classification of VAP. VAP can be classified into early onset as well as late onset. Early onset VAP is supposed to occur within 4 to 5 days after the initiation of mechanical ventilation. This is generally a less severe form of VAP, and it generally has a better prognosis because the antibiotic sensitive bacteria causes the early onset VAP. Whereas the late onset VAP usually occurs 4 to 5 days after the initiation of mechanical ventilation. These are caused by multi-drug resistant pathogens, and they generally have increased morbidity and mortality. So having this background in mind, let's proceed further. The primary outcome of this study was the proportion of patients developing early VAP from the second to the seventh day of mechanical ventilation. This was done using the ATS, American Thoracic Society definition, except that the time limit of the occurrence. Instead of 5 days for the occurrence of yearly VAP, they have chosen 7 days. This is based on the fact that previous studies have found the developing of antibiotic resistant microorganisms remains low until day 8 in patients with acute brain injury. Secondary outcome at the discharge from the ICU or at day 28. The proportion of patients developing late VAP, type of microorganism causing VAP, exposure to mechanical ventilation and antibiotics, digestive acquisition of ESBL producing Enterobacteriaceae, and neurological outcome that has been assessed by modified Rankin scale and Glasgow outcome scale, mortality and safety. At day 60, they track the number of ICU free days and hospital free days, neurological outcome, and mortality. So this is the general patient characteristics that has been done in this study. The ceftriaxone group and the placebo group has been mentioned. So as you can see, the age, sex, BMI, and the various medical history have been comparable among the both groups. Among the causes of main severe brain injury, subarachnoid hemorrhage accounted for majority of the cases in the ceftriaxone as well as in the placebo group, and they have been comparable, followed by brain trauma, hemorrhagic stroke, and ischemic stroke cases. The GCS score between both the groups has been comparable, and most of the patient has the GCS score of 4 to 8, which is also comparable between the group. And various other parameters such as SAPS-2 score, time PF ratio, temperature, WBC counts, all were comparable between both the groups. So coming to the results, the primary outcome, which is the incidence of yearly VAP, was found to be 14% in the ceftriaxone group, whereas it was found to be 32% in the placebo group. So it is almost half the time, or half the time reduction has been done, with the hazard value of 0.60, with the confidence interval 95% confidence interval being significant and with a significant p-value. So there is a significant reduction of yearly VAP in the ceftriaxone group. When we look at the secondary outcomes on day 28, the overall VAP incidence and the late VAP incidence have been listed as mentioned, and the number of ventilator-free days was found to be more in the ceftriaxone group when compared with the placebo group, and this has been found significant. And the number of antibiotic free days was found to be higher in the ceftriaxone group when compared with the placebo. The modified ranking scale was also like much better in the ceftriaxone group on the day 28. And the overall mortality was 15% in the ceftriaxone group, whereas it was higher, 25% in the placebo group. Secondary outcome on day 60, ICU free days has been found to be 34 and 26, and patient had significant ICU free days and the hospital free days. But when it came to the modified ranking score, which is the neurological outcome, it had become insignificant on day 60. As you can see in this graph, the hospitalization time plotted against the cumulative incidence, the ceftriaxone group tended to have lower incidence of yearly VAP on the day 7 when compared with placebo, and also it has been still continues to be in lower side when compared with placebo group on day 28 as well. The various adverse effect that has been occurred due to the patients during the study has been listed here, but all these serious events were attributed to the initial disease and it is not due to the trial intervention. The microbiological documentation of yearly VAP has been listed here. The organisms that occurred in both the groups were comparable. The most common organism that caused the yearly VAP in the ceftriaxone group was E. coli, whereas in Haemophilus influenzae caused the most common VAP in the placebo group. Among the gram-negative bacilli. Among the gram-positive cocci, methicillin-sensitive Staph aureus was the most common cause in the placebo group, whereas the Streptococcus species caused the most common in the ceftriaxone group. So, among the 115 patients with the rectal swabs, only 2 cases of ESBL producing Enterobacteriaceae acquisition was observed during the ICU stay, and both of them were in the ceftriaxone group. 3 patients developed Clostridium difficile infection, one in the ceftriaxone group and one in the placebo group. Coming to the discussion, the incidence of VAP in the comatose patients varies widely from 20 to 53%. This is influenced by various factors like coma, origin, VAP diagnosis method, and the study design. In the current trial, the overall incidence of VAP in patients was found to be 28%, which is relatively lower. This could be attributed to the systematic implementation of bundles to decrease the VAP in the ICU and to the adjudication of all suspected cases of VAP. A similar trial has been conducted previously called the Antarctic trial. It is a randomized placebo-controlled study which involved the adult patients on mechanical ventilation after out-of-hospital cardiac arrest with shockable rhythm who received targeted temperature management and were randomized to receive either IV amoxiclav, augmentin, or the placebo within 6 hours after the cardiac arrest. So in this study, the prophylactic antibiotic reduced the yearly VAP, but it did not improve the ventilator exposure, ICU length of stay, or mortality. No emergence of difficult to treat microorganisms on pulmonary samples were found. ESBL producing Enterobacteriaceae acquisition in rectal swabs and Clostridium difficile incidence was low. This finding was in line with the Antarctic trial. So concluding, an early single dose of ceftriaxone effectively prevents the yearly VAP. There has been decreased exposure of antibiotics and mechanical ventilation. There is a mortality reduction observed at day 28. The ICU and hospital stay were found to be shorter with no safety concerns.
Hello. Coming to the coming to the critical appraisal of the trial. We will check the trial on the basis of the validity, how is the methodology, the reliability of the results, and are the data applicable in the current practice. Coming to the merits of the trial, it was a multi-center trial. As we all know that it increases the generalizability of the study and make the trial robust. The inclusion and exclusion criteria were clearly defined. The trial was a randomized controlled trial. There was a allocation concealment in this trial. The baseline characteristics were comparable in both the groups, and even the patients were stratified at the time of randomization on the basis of GCS, on the basis of leukocyte count, on the basis of PaO2 FiO2 ratio. It was all patients, healthcare provider, assessor, and the study statistician all were blinded. A appropriate placebo was used. The vials labeled as Profivab were used for the trial, and the Profivab vials contains both normal saline and ceftriaxone meat vials. The co-interventions were excluded at the time. The VAP diagnosis was done by a central adjudication committee who was masked to the study, and anonymized charts were declared for the VAP diagnosis. The secondary outcome were clearly defined. Coming to the results reliability, there was no deviation from the protocol, and the proper statistical analysis was done. Coming to the limitation of the trial, the primary outcome is itself challenging. The diagnosis of VAP always remains challenging, as we all know in our ICU. It has three criteria: the clinical criteria, microbiological criteria, and radiological criteria. Fever may be present in acute brain injury patients without VAP, and we know that colonization of the bacteria even causes the positive culture, and there is a great inter-observer variability in radiological diagnosis also. A diverse group of patients with traumatic brain injury and non-traumatic brain injury were included in the trial, and there is a significant difference in the VAP incidence in both these patients. As the patients who are having traumatic brain injury, they have significantly higher incidence of the VAP. The VAP preventive measures were used in the study, like head elevation and other measure, head hygiene, oral hygiene. Even oral hygiene was not followed. Oral hygiene was not followed appropriately in all the centers. Some centers used normal saline, and the other centers used chlorhexidine as a oral care. And the data is not given in the study about the compliance of the VAP bundle. No data is given in the study about the lung injury at the time of randomization, as no chest X-ray was done at the time of randomization. The treatment blinding was not done in the pharmacy. It was done by the neighboring nurses who can even unmask the procedure. The ceftriaxone, the effect of ceftriaxone on bacterial colonies in intervention group uh, is the ceftriaxone was given in all the patient, and it can affect the quantitative analysis of the bacteriological colonies in the intervention group. So there may be decreased incidence of the microbiological data in the ceftriaxone group. The protocol was not designed to monitor modification of the digestive microbiota, and the authors did not study the impact of the ceftriaxone on infections other than VAP, and the choice, spectrum, and the duration of the subsequent antibiotic treatment is not mentioned in the study. The antibiotic resistance is not followed for the longer time. They mentioned the antibiotic resistance only up to 7 days. The study was conducted only in the ICUs in France. So what is the external impact on the other countries? It's not known. So coming to the applicability of this study, a clinical trial on the base of this study can be conducted using a prophylactic antibiotic according to local antibiogram. Because the antibiogram is different in different ICUs, so even on the basis of this study, as they found a significant difference in the early VAP, they found a significant difference in the antibiotic free days, and the significant difference in the mechanical ventilation days in the patient. So for the patient benefit, if us giving a single dose of antibiotic is effective to decrease the antibiotic free days, so we can also conduct a study in our center to find out the applicability of this trial. The choice of antibiotic can be depend on the local antibiogram, whether we are choosing second generation cephalosporin, third generation cephalosporin. It uh, it varies according to the different ICUs. And there is a thing that if we choose an antibiotic, if we choose a higher level of antibiotic for giving a prophylaxis, then it increases the antibiotic resistance. But in patients whom we suspect that the patient will require lesser days of mechanical ventilation, we can definitely try a antibiotic prophylaxis at the time of in this at the time of intubation to decrease the early VAP. And hopefully this will be beneficial for the patient here also.
Thank you, ma'am. Thank you, Dr. Sali, for that very lucid presentation. And Suman, ma'am, had wonderfully given a critical appraisal. Just a few questions. So, what is the practice in your ICU, ma'am? Like, what antibiotic is your prophylactic choice in?
No, in our ICU, we are not giving any prophylactic antibiotic for VAP prevention. The patients who are coming after surgery, the TBI patients or other patients like SH patients, they receive a prophylactic antibiotic only for surgery. They don't receive, the patients who don't undergo any kind of surgery, they don't receive, and having a closed head injury, they don't receive any kind of prophylactic antibiotic here. If the patient is having open wound, then definitely they get antibiotics.
Okay. And also, one thing really interesting about all the trials in VAP is most of the trials have come neutral. For example, the trials which Sali had also discussed, and also selective decontamination of gut. That was also one of the largest trials done, which also showed a neutral result. But the post hoc showed a positive result for patients with acute brain injury alone. So,
Hmm.
probably the explanation could be in our set of patients, we see aspiration much more compared to the other ICUs, and probably that's the reason why these things of prophylaxis maybe help in this. And also, what is the VAP rate is very different in India compared to other countries. In this study, it is around 28%, and definitely in our ICU, it's much higher than that, I would say, because there's a lot of hospital shopping. Patients move in from one hospital to another, and we get a lot of gram negative infections compared to other ICU. So, what's been your experience, ma'am, in this?
Yeah, definitely. The incidence of VAP is very high in our ICUs. And the important thing is that you when we send sample for VAP, usually the infection is although the early VAP and late VAP is changing, even the bacteria who were earlier causing late wave, they are also causing early wave these days. And in our ICU, mostly we get the carbapenem resistant Acinetobacter baumannii, carbapenem resistant Klebsiella. These are the most common and most common organisms causing VAP, usually causing late VAP. But if the patient whom we think that the patient will be extubated in 3-4 days, like the patient is a uh, uh, like good M5 or having a good skin post-operative or pre-operative, and we think that the patient will be extubated early, then definitely we can try a prophylactic antibiotic in these patients.
Yes, ma'am. Another
Yes,
one
ma'am. Like
point
you
to be
said,
noted.
yes, Mohammed. Yeah.
Uh, like we have discussed, there is a classification for VAP based on the type of microbial organism, early VAP and late VAP. And the traditional teaching is that early VAP is due to antibiotic sensitive organism. But recently there have been studies that have challenged this classification, because in many places like early VAP was also caused by resistant organism. So this classification itself has been challenged. And we also have to consider the local antibiogram. Let's say for in our setup, like we have been getting more carbapenem resistant organisms, like the carbapenem resistant Acinetobacter baumannii, or Enterobacteriaceae, etc. So if we go ahead with the antibiotic sensitivity for early VAP, like we might be even misguided, like we might delay the treatment of resistant organism which are causing VAP within the 5 to 7 days. So the studies, this has been done in this French university, only in the France. Maybe we could have a study from India, and especially based on the local antibiogram, like we can further do studies to decide whether antibiotic prophylaxis will be helpful to prevent early VAP or not.
Yeah, that's a very good point because our organisms are completely different. Our practices are very different, and also there is also a variability in India between open ICU and closed ICUs. So exclusivity of neuro ICUs are not there in all setups. So obviously, the exposure is to community-acquired pneumonia and so many other things which will lead enhance the infection rates. And also the antibiotic stewardship completely. So whenever you talk about prophylaxis in antibiotics, that is something frowned upon because antibiotics should not be given. But like ma'am you said, if the patient is going to get extubated in 4 or 5 days, and if there is a benefit given, a single dose should help these patient, because VAP is going to take back a neurological injury patient much back in their recovery, and it's a single important risk factor for mortality among acute brain injury also. So on behalf of Neurocritical Care Society of India and Classroom Series, I thank both of you for this wonderful presentation. Have a nice evening, and we wish to invite you on many more forums like this. Thank you very much.
Thank you.
Thank you, Dr. Matangi. Thank you very much for giving us the opportunity.
Yeah. Okay. Bye bye.